Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago, HC3. My name is Megan Phillip, and I am the Executive Director of HC3. We are a mission-driven platform proactively seeking uncommon alignment to improve Chicago's healthcare ecosystem. I am proud to announce the release of HC3's white paper, The Challenging Future of the Chicago Safety Net. This report was a collaborative effort, and I want to thank our sponsors, Medical Home Network and Sinai Chicago, for their generous support to make this publication possible. In today's discussion, we'll be joined by local leaders to discuss the economic, political, and structural barriers impacting our most vulnerable communities with the hope of identifying solutions and opportunities for us to embrace a transformative approach to Chicago's indispensable safety net. Before we dive in, this morning's discussion will be recorded and shared on our website for later viewing and sharing. And as we hear from today's experts, if you have questions, please use the Q&A function, which will be seen directly by our moderator, who will do his very best to address them during our audience Q&A later in the program. To get things kicked off, I am proud to turn things over to my colleague, David Smith, founder and CEO of Third Horizon Strategies and HC3 co-founder.
Megan, thank you. Thanks to everybody that has taken time out of their schedules to dial into this or watch it on the website after. This is a discussion we've looked forward to really since the inception of the idea of the paper. And so we're excited to invite our colleagues into the discussion and try and recap some of the things we concluded and observed as part of the most important things to pay attention to in the safety net and really what we need to do about it going forward. I thought I would just share on the front end, the title of the white paper has kind of a very generic, it's a very generic description, The Challenging Future of the Chicago Safety Net white paper. And we wrestled a little bit with the title and settled on that as a means of trying to not be too shock and awe. But I think if we were going to retitle the paper and try and be shock and awe, it would be something like The Safety Net is on Fire, or The Safety Net has 2 or 3 years left of runway before it hits a brick wall. And that both of those statements, I think, would be accurate. To me, it has started to feel like we have reached a place in our city where we have come to accept the status quo, and we have all been aware for a long time about the issues and the challenges some of our neighborhoods and neighbors face, and we've all kind of known where we have asymmetry, but we've also collectively chosen to not be serious about some of those challenges and issues, looking to Springfield to patch things up with the budget every year and help keep hospitals moving, or looking to the political process to help fuel different opportunities for different parts of the city. And in the meantime, over the years, we have continued to inadequately provide resources that would not just support health, but also support the economic development of our communities. And the discussion we want to have today is a little less about healthcare. I've come to define the issues around this, both in our work with the council and in the work we do in our firm, as being uniquely focused on health. And the way I at least frame this for myself is that a person's health is their most precious and indomitable asset. It's something that when we don't have it, we are painfully aware of it because it renders pain to us, whether it's physical pain, mental duress, or social burden. And what's more is because of the pain that it can inflict, it prevents us from being able to do the kinds of things we all aspire to do as human beings. It's hard to work when you have an abscess in your tooth. It's hard to go to school when you're balancing your diabetes management. It's hard to raise children when you don't know where you're going to live from month to month or year to year. And it's poor health saps human capacity. And what's more is it robs us of precious people in our neighborhoods because of this life expectancy gap that we've all become so attuned to. That people a few miles from where I'm sitting right now are more likely to die 15 years before I might, is one of the most sobering thoughts in the world. If anybody in this meeting knew that there was something they could do to extend their life 5 years, 10 years, 15 years, or the life of your children or your parents, there's nothing any of us wouldn't do to create that as an outcome. And yet we don't do that collectively for so many people. Regrettably, people of color, people that are burdened with poverty, and the like. So it's a sobering beginning to the discussion, because it's a sobering and serious topic, and it's something that we have to stop looking to others to solve. I've long been a proponent that we really, in many ways, have the things we need to solve this. We continue to get in our own way. And so it's our hope that the paper, that this discussion, both live today and as it's recorded in the annals of the website, will at least serve as a contribution to that discussion. And we do have 4 just incredible colleagues joining us for this. And I was actually thinking a couple minutes ago, I can't say that this was done with complete intentionality, but we have an almost perfectly strategic slate of executives. And so I'm going to introduce them while telling you why I think it's kind of perfect. So we have George Miller, who is the president and CEO of Loretto Hospital. That is a West Side institution. We have Brenda Battle, who is a senior vice president for community health transformation and chief diversity, equity, and inclusion officer with the University of Chicago Health on the South Side. We have Karen Teitelbaum, who is the president or the CEO of Sinai Chicago, which has a South Side and a kind of West Side, Southwest Side facility with Mount Sinai. And then we have Cheryl Lulius, who spent the last few years as the CEO of Medical Home Network, connecting all of them to federally qualified health centers and each other to try and better coordinate care. So we are well geographically represented in this discussion, and well represented in the context of what we can do differently, both in the new tools we have coming available to us, funding that is going to be moving its way from the state and into the city, and things we ought to be considering for hospitals as we move forward. So I'm going to talk a little bit less because this time is going to go fast, and I'm eager to ask a bunch of questions. And I really had no idea who I was going to start with, and I still don't know. So Karen Teitelbaum, you draw the honors as being kind of in the middle of it all. You've got a foot to the west and a foot to the south, and I obviously have the opportunity to serve on your board, and so know a lot about you and how you think about these things. Karen, maybe just take a couple minutes and describe to you, why does this matter? I at least gave my opinion, and why does this issue affect everyone? I've been saying, Chicago is the symbiotic ecosystem, so just because it's not happening in your neighborhood doesn't mean you're not feeling it. Like, do you buy that?
Oh, that sounds like a loaded question, David. I'm going to put aside the do I buy that, but to go to your question, why does it matter? Having spent the last 15 years at Sinai, and why does it matter? I'll tell you why. We serve communities of color. We serve these most vulnerable communities. You take a statistic, if it's unemployment, we've got 7 times that of the rest of Chicago. We've got 3 times the homicide rate of the rest of Chicago. We've got 3 times the diabetes rate of the rest of Chicago. So what did that all mean? During COVID, it meant that patients who came to Sinai from these vulnerable communities had a mortality rate of up to 18% because they came with so many comorbidities that resulted in death, as opposed to the rest of the city and the rest of the state, at that time had a morbidity rate of about 4.5%. So why does it matter? I think it ties directly to your opening comment, David, about the difference in lifespan. I know that's something that my colleague George talks about with me, with others in the hospital industry, and wherever he can all the time. So that's why having care available, having quality care, easy access, working together to reduce the barriers. We don't want to see that kind of discrepancy in mortality rates, in lifespan. That's why it matters. We need the safety nets to be stable.
Yeah, I couldn't agree more, and I do think we had approached this paper with it being in the context of being a stress test, and it obviously has a hospital finance orientation to it. But if we think about what we've been through over the last year, we've been through a giant cultural, social, economic stress test, and these communities certainly have been. That said, I also tend to bristle a little bit when I hear on the news right now when people say, well, it's shown a light on all the disproportionality we have between the underserved and the better served. And none of this is new. We have known about, we have studied, we have known these things for years. And I have this fear that there's going to be a tendency to revert to the mean when we're all said and done with COVID, whenever that takes place. So Brenda, let me come to you for a moment and invite you to give some opening remarks. I'd be really interested. The thing that has always struck me about you, Brenda, is like anytime somebody's collaborating somewhere, like your name comes up just instantly. You seem to be very active throughout and with community organizations. Brenda, will you just talk a little bit about where you think we're getting it right in collaborating across communities for the right reasons, and where you think we're getting it wrong?
Yeah, so thanks for that. So first of all, I'll start by saying that not one institution in Chicago or Illinois, not our government, the state, can solve the issues that are born in our communities. We just can't do it alone. It requires collaboration to do it. And it requires multiple types of stakeholders to do it, not just one type or one industry type. And that's why you see me in a lot of places, because I've known and learned over my career and spent much of it doing community collaborative work, that it takes, a real village to get this thing done. So where do we have it right? So it's interesting. There's been a lot of collaborative work going on, kind of, that's been territorialized across Chicago in particular. I came here about 9 years ago, and there was differences with the South Side and their collaborations and the West Side and their collaborations, and outside of research, didn't see a whole lot of work with North Side and other parts of Chicagoland. And then when COVID hit, to your point, we that do this work all the time we're very much aware of the disparities that existed within our communities. It created some what were unnatural collaborations. It brought the West Side and the South Side together around how are we going to address the issue, starting with COVID testing? How are we going to get it into these most vulnerable communities? And how are we going to leverage the resources within our respective territories to do this? So West Side and South Side hospitals and FQs and community-based organizations started working together. And I think that was right. That got it right. And it started this energy around, look, we can't divide the West and South Side by, boundaries anymore. We got to do this thing. We got to do these things together. And since then, there's been a lot of collaboration around how do we address some of the issues that we see together, some that we had not been involved in early on. So I think those are some things that we got right. There are some other things that were right, but again, I felt like from my perch, they were a little more territorialized. And I think that the boundaries are breaking down. I think this transformation work is starting to break down some boundaries that we hadn't seen before, and having communities and providers and community-based organizations realize that we can't do this thing alone. So in that sense, I think we're starting to get some things really, really right across breaking down boundaries and working together.
I've had a similar instinct over the last few months. So to hear it from you, Brenda, who I think has her finger on the pulse a bit better than I do. It's validating and it's comforting to hear that sentiment. There's a couple things I'm excited to dig into in a few minutes with you. A couple things you just said that I'm just very curious about. I do want to take one thread you said and maybe flip a question in George Miller's direction. And that's around this, the boundaries, the barriers that we've had up in this city. I haven't been in the city for much longer than 7 years, but in that period, and particularly the period I've been doing this work, I'm just astonished at the level of politics that exists in this city's safety net. It just literally just does not compute for me, because if the mission is focused on communities and improving people's lives, why are we not able to get our stuff together? And so, George, the reason I'd love to have your thoughts on this is you've run systems, like you've been all over the country in your career. You're like me, a bit of a newer transplant to Chicago. Maybe contrast what you see in this environment here to what you've seen in other areas. And based on what Brenda said, are we on a path to improving this? Or do we still have some other boundaries? And you were muted, George. Sorry.
That's okay. Thank you,
Gotcha.
David, and thank you for inviting me to participate in this illustrious panel. I'm so very pleased to be with my colleagues, Karen, Brenda, and Cheryl, and certainly you. You pose an interesting question. Yes, I've only been here 3 years, and I've been in different markets and in different communities, 5 different states. I came here from Austin, Texas. And what was unique about Austin versus here, to draw the parallel of your question, the citizens of Travis County, home of Austin, Texas, decided that even though the state with the governor, which is a different governor, would not expand Medicaid. So when the Affordable Care Act came, they could expand and give more Texans health insurance that would then be able to give them greater access to health care. The citizens of Travis County taxed themselves an additional nickel to provide for services for the poor and vulnerable population in Travis County with community care, where I was president and CEO. And we were the largest FQHC in the state of Texas, the 10th largest in America. Then we went after 1115 waiver funds to pull down district funds to even span that. We had a homeless clinic, but we worked with colleagues like Karen and Brenda, the leading healthcare providers. We coalesced and worked with community-based organizations, and we looked at the landscape of all of Travis County, tried to make sure we had clinics, and we grew pretty rapidly. When I first came there, we had 17 clinics. When I left, we had 27. And we strategically located them where the greatest need was. And we all worked together. And this is the county, of the city of Austin, Steve Adler's the mayor, and the health district was called Central Health, to provide the infrastructure for providing care. I was very proud. We built out an OVA hospital, converted that to the largest clinic in Texas, and we did that with taxpayer dollars. But what we provided is 75,000 square foot, the largest clinic in the state of Texas, but we had every modality there for all of the patients who come there, including the University of Texas Medical School, which is now called the Dell Medical School, right there in Austin. Their students can learn right there collaboratively. We hired an endocrinologist. We provided all of the needs that patient could need. And I used to joke that we did everything from the womb to the tomb, from birth to the hearse, so that you had all comprehensive services. But when they needed, and we were patient-centered medical home, but when they needed a higher level of care, our partners at Seton and St. David's, we didn't send those patients there, but then they came back to us, so we established medical homes. So as Brenda talked about, having that collaborative effort with everybody working on from the same sheet of music and working to end the disparities in healthcare. And I think that is a wonderful model. Chicago's a little bit different. You mentioned about the political arena here. But we do have a wonderful opportunity going forward, because your paper, and I loved your paper. I love the metaphor about we're running out of runway. I'm a pilot, so I love that metaphor. But moving forward, the things that you mentioned in your paper are just real, and hopefully this could be a catalyst for getting everybody around the table and use the term that I heard you use, but I've used also. Can we reimagine how we do healthcare, and how do we deal with not only the delivery of healthcare, but all the social determinants of health, like food and nutrition and housing and transportation. But one of the most important things for the future of healthcare is making sure every community has high-speed internet, because you won't need to necessarily come into the hospital to check your diabetes. You could do that over line, but you have to have high-speed internet to do that. We could ask every man, woman who have ever smoked 45 years of older and come in and get a complete checkout and see if there's any of the vestibules beginning to have cancer or any problems. Do that early, so we prevent the long-term consequences of developing cancer. If we can catch it early and nip it early by doing diagnostic testing through a CT. So there's a whole plethora of things that we can do if we just, again, your term, reimagine how healthcare is delivered, not the way it's been done in the past. So I would agree with you. We have to rethink where the right place and the right system. But I would caution, I would caution that in your paper you mentioned that even though we spend tons of money on the Medicaid problem, we still have a lot of disparities. I would submit, and please forgive me, I'm a hospital CEO, so I look at the numbers, that the state Medicaid program, while it has merits, there has not been a raise in the state Medicaid program since 2011. That's more than 10 years ago, and we've got to do the same thing with that same pile of money when all the other expenses have gone up. So I would submit to you that part of the reason is the way we fund and how we do healthcare in the state of Illinois. And I realize it has other problems it's got to deal with, and certainly understand how the state budget works. But maybe part of the problem is the current way we fund the Medicaid program and administer it and doesn't create creativity and innovation, except for now the transformation fund that's recently signed by the governor. So we certainly can talk about that as well.
You phrase that so well, and I hope Karen forgives me and doesn't orchestrate me getting kicked off of her board with what I'm about to say. But one of the most salient experiences I've had in the last handful of years was one of my earlier Sinai board meetings, and Sinai is certainly, I would submit, one of the more innovative, thoughtful, creative safety net institutions in the country. Now I've kissed a little bit of tush, Karen. Now I'll cut to the punchline. But one of the things I observed is in this particular meeting, we were talking about some kind of telemedicine program or an asynchronous platform, something. It was technology based. And it's something that I in some other work I do, I see hospitals across the country kind of really getting deep into it. And we were very much at this high superficial level. And what occurred to me was we have put our safety nets in this position where day after day, week after week, month after month, they're managing tight cash, low reimbursement, community dynamics that are really difficult. We've not enabled our safety net organizations to make those investments, to spawn that kind of creativity, and to really drive, quote unquote, reimagining or transformation. So like, if I was a CEO in our city of a hospital, and I was listening to myself talk, I'd be like, go pound sand, because you have no idea what it's like. Like, reimagine, I'm just trying to manage X amount of days on cash. Like, we have to stop putting our leaders in communities with this false choice, which brings me to Cheryl Lewis. Sorry, that was a big windup, Cheryl. Cheryl, I've been submitting for a while that we can do all kinds of cool stuff with tech right now, and we've barely scratched the surface. You are on the leading edge of this. What do you think we can do now that we couldn't do 5 or 10 years ago, and why is that important?
Well, I'm going to answer your question, but I'm going to go back and pull on a thread from Karen, Brenda, and George. I agree with all of them that we're at a great inflection point, and we really have the opportunity to create a mission-based ecosystem, one that moves from a healthcare system to an integrated system of care, and one that's centered around whole person care and the patients and communities we serve. And I also think we have the opportunity to focus on the continuum of the care journey using traditional settings as well as other modalities, which gets to your question, right? So with that in mind, we have a great opportunity today. You know, we have technology that enables us to connect, communicate, collaborate in ways that weren't possible before. We have the ability to have data liquidity, to have real-time information popping up so we can share and look at, you know, the whole person record, which can enhance point of care decision making, but also how we coordinate care across the safety net or across the delivery system. So, you know, just in general, our ability to communicate and break down those silos, we've really accelerated our development on that front. Interoperability is a big thing that's being mandated. You know, we built a system of data silos and data tribalism. We're undoing that right now. And with the partnerships and the enlightened leadership we have now saying these problems are too complex to solve individually, we have to solve them together. That's being a drag along for information exchange. And then there's also the obvious virtual technologies, which the pandemic showed we could flip overnight to do virtual care. And now we can do so much more using tech, you know, virtual chronic care management, specialty care, telehealth, blah, blah, blah. So.
That's another thread I want to keep pulling on over the next few minutes. But I think what I've always admired about MHN is so much of that infrastructure and wiring has kind of been done in collaboration with a lot of important partners. I know we use Sherrill County Care and other state folks and MCOs. So there's a handful of topics that have kind of been raised thus far. Brenda, I'm going to come back to you for a minute, and then Karen, I've got a follow-up for you. Brenda, we're talking about we're talking about collaborating. And collaboration, in my opinion, requires a few things, but the two most important things are kind of a common pain that motivates people to not just come to a table and sit down and be willing to give something up, but kind of oftentimes results in people doing things they might not otherwise do. And then it requires a convener of stature. And I, like many Illinoisans, Chicagoans, have been quite impressed with some of our political leaders during the last year. What a terrible first couple of years it would be to be mayor of Chicago. I think Mayor Lightfoot has risen in many ways to the challenge and reoriented our city's thinking about some really important areas. I think Governor Pritzker's done the same. Kat, I don't know your last name, but I'm watching the chat box here, just did a little chat that said there's a new council under the SHIP plan that has been put together under the Pritzker's administration. So we know there's activity there. The question, Brenda, is what is the role here of the state or the city? And and what is the role of the community, and how do we get that moving? Because I know we all attend these meetings and we all want to do it. I think we've struggled to kind of find like what's the northbound train, so to speak.
Yeah. I'm going to say that's a loaded question, like Karen said when you asked her the first question, what is the role of the state and the city? So you first started off the discussion about saying you need, high power folks to convene groups around solving these complex issues. And what we have now is the issue of our safety net survival. And that is one of the most major complex issues that we face. So while the city and state shouldn't drive those collaborations and those discussions, they need to be at the table for them and should hear what the community's perspective is. What I have learned over my years of working in communities now in 3 different states, and I would say that the Chicago community is probably one of the most engaged of those 3 states that I've worked in, is that they know what their needs are. They don't know complex, medical language, but they do have a good understanding of what the community needs to enable them to have wellness and health. And they don't necessarily define it the way we do in healthcare, but they know what it is. And I think that, as decisions are being made about what can transform communities, the voice of community members at the table with state and city leaders, institutions, health departments, as well as the mayor's office and the state, and the healthcare stakeholders and community members and community organizations and faith-based organizations. It's about having the right stakeholders at the table. And so their role is to be there to hear and listen. And as we're all striving to create solutions to address these issues, they need to be a part of that. And some of the funding opportunities should be set aside to address those issues from that perspective. And so I think that, and I've seen more of that as of late. I think the transformation funds is evidence of that. I think some of the things that are happening out of the mayor's office, particularly around COVID and testing, that those are examples of that. But there needs to be more of that. The silos and the fragmentation that has existed for years in this community and other communities also include the city and state. They're part of those silos and those fragmented systems that need to come together. What George described in Austin, Texas was a coming together of the city and the state and the healthcare and community-based and hospital and academic institutions together. And the result was what he described happened, including getting a 115B waiver and getting disrupt funds, which Texas, as we know, got a lot of those disrupt funds.
Yeah.
And so it takes that, because we need to look at how we as a collective working together with the state and the city and all of these other stakeholders could go after some of those major funding that could be brought into Illinois to help enable the systems better. So that's some of the things that the state and city, and I'll stop there. I have all kinds of thoughts because I spent 7 years of my life in government affairs. And so I have tons of other thoughts around that, but I'll stop there.
No, it's a really helpful answer. I just, one really quick follow-up, and then Karen, if there's anything you want to pile on, and then if not, I've got another question. Brenda, how, just in your view, how well or poorly have we done at engaging the community over the last few years? And if not great, what do we need to do to get that right? Because I agree with you. That's your ticket to ride.
So the collective hasn't done a good job, but independent groups have done a good job. So I don't think we've put together, corporations, businesses, public, private, city, state, and healthcare with the community. We haven't done that, but I know that institutions within these communities have done a better job. We've done it. Sinai's done it. Rush has done it. A number of the particular systems have done it. Loretto's done it. But no, we haven't done it as a collective. And I think that's the problem. This is something that has to be done as a collective. It's silo when it's just healthcare providers pulling their communities together to address complex issues that it's going to take more than healthcare institutions to solve for. And so that is what's been missed when it comes to this collaborating with the community. It hasn't been in a collective approach. We have not done well with that. We have to do better with that. We've done the COVID situation has done, has ebbed us to do more than that, but we've got to keep doing that, and we've got to do it at the magnitude that's required to help our city and state.
Yeah, it was really well said, Brenda. And by the way, having not done that, my opinion, I don't live in some parts of the city that are vexed by some of these challenges, but I suspect we're only widening the fissure of trust and credibility by not doing that, and making it even harder, well-intentioned or not, to be supportive, useful, and good partners with our communities across the city. Karen, anything you'd like to layer on here? And if not, I would love to ask a little bit about our doctors and the men and women that get up every day and do this work.
Okay, well, I am going to take advantage of layering on a little bit to what Brenda said, because I think that there are some positive things that are going on. Not that what Brenda said was painting this as negative, but just more opportunity. So when we look, I'm encouraged by some of the more recent collaborations that are unique, far-reaching, and I'll give you a couple of examples. One is the establishment of the corporate coalition, which has around the table, and HC3 is one of the early members. Sinai has been a member, has around the table, really, I think some of the most important civic organizations that really deeply care about Chicago, and they care about what's going on in our vulnerable communities. And what I love about the corporate coalition, they're tackling several different areas, but the entire thing is aimed at really encouraging these corporations to invest, not just to write a check, but to invest their assets in our vulnerable communities. I'll give you just one example. Ogden Commons, which is, Sinai is part of Ogden Commons. It's a large development that's got commercial, we're going to be an anchor tenant in there, housing, about 500 units of new housing, and also professional space and retail. Wintrust is opening up a branch there. It's right across from, it's on Ogden and California, right across from the Mount Sinai campus. And when we look up and down that street, there's no bank right now. Where do our folks go to deposit a check? What's readily accessible? So we're looking at financial literacy, banking, mortgage. I mean, these are the kinds of things, when Brenda talks about health and wellness, the kinds of things that contribute to a community's health. It's being safe, it's housing, it's education, it's the totality of what we all want in our communities, not just the healthcare. So I love the fact that Corporate Coalition is really aimed at how do we invest, not just write a philanthropic check, but how do we invest in these communities? So Wintrust is one that comes to mind. Okay, David, I'm going to let you. Okay. One other thing. Sorry, David. That's what you get. That's what you get for letting me take a breath. So, another thing I think has been just super positive, and hats off to Mayor Lightfoot and this administration, because they've made Invest Southwest real, tangible, literally putting money where their mouth is, into these vulnerable communities, choosing projects that will better the communities, and making it front and center of how do we lift all of Chicago. I live in River North, and 6 miles west, is Sinai. And it's like 2 levels of healthcare, and that's just unconscionable.
So Karen, I'm going to stick with you for a minute, and then George, I'm going to kind of ask both you and George a question as being our resident hospital CEOs on the panel. Julie Amos, who I know we all know, is listening in. So hi, Julie. And put a comment in the chat box that says Westside United has been collaborating at the provider community level. So Westside United, another great effort in the city. And then she said, which is cutting, but doesn't it require fundamental system change with all partners actually willing to change? And boy, isn't that just at the core of it? So we all know change is hard and uncomfortable. And if I kind of riff on Julie's point here for a moment, we have plenty of these forums where we get together and we talk about transformation, reimagination, and the need to change. And then when we sit down to get to brass tacks, somebody says, "Oh, you meant I have to do something. I have to change." It's not comfortable. Karen, George, like, what would you guys? And obviously, it's a big question because you don't know a lot of dynamics. But what do hospitals have to do to change? And how hard is that for you guys?
Yes. So go ahead, George.
I was going to say, and it's hard to have 2 CEOs who gets the mic first, but I will say that Karen was very gracious and invited the Loretta Hospital to participate in a larger group. And there's a West Side Coalition consortium come together. It includes UIC to do exactly what you're talking about doing. Are there ways we can work together? And the key element of that invitation was to work together to improve the outcomes for those who have been exposed to inequity and disparities in healthcare. And so I believe we're getting to see that. Again, Karen's one of the leaders in our community, and she invited us on this project and another project. And so it takes that type of collaboration and willing to work very closely with your partners. We have a wonderful partnership with the Cancer Center at UIC. When Dr. Wynn was there, that was begun, where we're trying to address the problem and the inequities of healthcare here in our community, especially around cancer in women and breast cancer. So we're working collaboratively with them, but it is going to take much more than that. So one of the things that you mentioned, David, I love to say, and I'm kind of known for saying this, but if you live in downtown Chicago, life expectancy there is 88.2 years of life, but you just come 9 miles on the Eisenhower to exit 23B, where the Loretta Hospital is the beginning of the Austin community. It drops down to 68.2 years of life. You lose 20 years of life in a 20-minute drive. So we, the Loretta Hospital, cannot do it alone. That disparity, that gap cannot be done alone by us. So we have to partner with other organizations like Mount Sinai, Sinai Health of Chicago, UIC, and others, because that distance, that gap is too profound for one individual or organization, as much as they would like to address the bigger problems. And those problems not only exist in the disparities of healthcare. Again, I mentioned about housing, transportation, food deficit, and even in dealing with COVID, we don't have as many per capita drugstores in the Austin community as other communities. So there's a whole plethora of issues that we've got to deal with. And I think one final thing is we've got to reimagine how healthcare is done, and clinical integration and having the right, you mentioned interoperability, being on the right platform today. Much as we have technology, I have in my wallet a card that I can go anywhere in the world and get cash out of my bank right here in Chicago, Chase Bank, out of my bank account, and I can go anywhere in the world and get that money out. But yet, if I go to another city, let me go on the north side of Chicago and need to go in the hospital, and they can't get my records here right at Loretta because we don't have interoperability. We can't transfer healthcare information, things we've already done one time. We duplicate that and triplicate that at other institutions. So that has to be worked out too. And part of the consortium that Karen has invited us to is trying to address that issue.
George, thank you. Karen, just to you, and then Cheryl, I'm coming your way. Karen, same question. I'm going to, just based on something George said that triggered a thought, I'm going to just put a slight variation on the question. In the paper, we kind of go to some length to set, like, here's two pathways. Pathway one is like, let's just continue to not be very great at this, be very platitude centered, and try to keep things moving as they are through subsidies until we run out of money. And we're going to see more Westlakes, Metro Souths, and Mercies. Pathway two is we figure out how to get our stuff together here and doing some of the things we've talked about today. And we do this reimagination exercise. What do hospitals look like in 5 years in Chicago in that second path? I think there's this fear that means we're going to have to close a bunch of hospitals, but I don't think that's what it means necessarily.
Yeah, I agree with you, David. And one of the things I was thinking of, and by the way, George, thanks for those shout outs. That's why I like you to go first. So one of the things that I think is so germane to how quickly and how effectively we, the hospital community, will be able to transform care and get out of this, business as usual. I don't think we can avoid the reality of the payment system. We are not incentivized to keep people well. We've got really an army of community health workers, and that's something that Brenda and I talk about a lot as we look at the South Side, and they do a phenomenal job. It's quantifiable, it's replicable, it's scalable, of keeping people healthy, addressing chronic diseases. And by the way, when we do community health workers, we're taking people from the community, respected members, we are training them, we're giving them a job with a good future. So we're also getting at that unemployment piece. But you know what? I make more if I amputate somebody's leg as opposed to controlling their diabetes. What is wrong with this picture? So can't we invest more in the right things? And then we would be able to be weaned off of the thing that's our economic engine, which is the admissions. And so I think that we've kind of got that backwards, and that is a big thing.
If only we had invited somebody to the panel who has borne risk and put together a coalition and managed it with. We've got Cheryl Lulius. That's right, Cheryl. You've done this. I want Cheryl. I'm interested in getting at the core of Karen's question, which is, okay, hospitals have to structurally change. What do we need payers to do now that we're on the back end of all this M&A activity? To Karen's point, I've been thinking a lot about this tug of war lately, and we like to be as crude and succinct as possible. We have one big part of the system that is incentivized to pay out less, and another big part of the system that is incentivized to charge more. And what we've done with providers in particular is we have put the safety net in our city in this awful, awful, awful position, because their very survivability means they have to kind of be beholden to the status quo. Like, making that flip is impossible without some of the things we've talked about. So Cheryl, surely like payers have to play a role. If you had the chief executives of every single MCO in our state on the call right now, Cheryl, what would you tell them?
Well, so going to Karen's point, and I was sitting here like hoping I'd be able to talk about what Karen, what the pandemic showed us is fee for service is risky, right? Fee for service doesn't reward on outcomes. We need an alternate payment model, and say no more. But we also talked about is the funding, the different sources of funding are one thing that we need to focus on, but we need to focus on an alternative payment model that rewards the outcome that we want. And to Julie's point, when we talk about fundamental system change, reimbursement is table stakes. So in terms of payers, payers obviously moving towards, sometimes I hate the word value-based, but value-based care and supporting the kind of clinical transformation and care transformation as part of the reimbursement model. Again, moving away from fee-for-service is certainly important. But I think there's an opportunity with whether it's philanthropy, corporate, Medicaid, the transformation fund is one good example. We have to prime the pump and create a transitional reimbursement model to invest in the safety net, to get us to where we want to be, so we could be on a true alternative payment model that rewards a safety net for outcomes. So I don't know that that's necessarily the payers. I think that's bigger than the payers, but I think we need to think about, and the state with their transformation fund is making good progress towards it, but we need to think about that alternative investment to get us to where we need to be. But fee-for-service is risky and it's not going to get us to where we need to be. And payers doing more value-based contracts and rewarding the care management and the comprehensive whole person services that Karen is referring to, and Brenda and George, is important as we think about how we engage with the payers and manage care in a bit of a different paradigm.
George, did I see you want to chime in?
Yes, I do. And Cheryl brought up a very important point. And to Karen's point, we do have an illness model of healthcare in America. We don't have a wellness model of healthcare. We pay for volume, and the more things you do to people, we don't pay to prevent people from getting disease process. So part of that redesign or alternative payment is we need a runway to get there, because we had to move from fee-for-service. But you're exactly right. When COVID hit and the governor said we need to suspend all elective surgeries, that took out immediately 40% of our revenue. And you're exactly right, Cheryl. That took out 40% of our revenue. That proved that fee-for-service does not work. So what can we put into place to help all of healthcare, and primarily safety net hospitals who are at the low economic end, to get us to that point? That's where rethinking healthcare and reimagining healthcare, bringing, again, as I described, the Austin model together, Travis County and Austin together, where we had both this taxpayers say, yes, we want to take care of the homeless population, the poor population. We want them to have health care, because if we keep them healthy, then all of us, the whole community, would be healthy. We've got to look at it from that holistic standpoint. And again, we got to deal with the other social determinants of health, including high-speed internet, because in the future, telemedicine, you don't need to physically come in to the hospital or the doctor's office. You can do that at home and be monitored at home. But we have to have a robust system to pay for that, and then more and importantly, to reward those healthcare centers who are incentivized to keep that patient well and out of our emergency room and out of our hospitals. 80% of our patients in our ED are primary care. They are not emergency. But we don't have an infrastructure of primary care physicians or community health centers, FQHCs, around the city to take off that burden off of our ER and get them better care. They should, an ER visit by one of our ER physicians is episodic care at the moment. What they need to know is the whole history and what the whole situation is of the life experience, to know what's the best thing to order for them. And it may not be a drug. It may not be therapy. It may be other things that we need to better deal with the disparities and equity in healthcare.
David, can I add something there? I completely agree with Cheryl and George about alternative payment models, but payment reform is also necessary too. George mentioned early on that in Illinois, we haven't increased the Medicaid rate since, I don't know if it was either George or Karen, since 2011.
2011.
Okay, so that in and of itself creates a huge problem for our safety net providers as well, that lack of, looking back and increasing, and the, kind of the model of, assessments, have helped, but long-term, is not going to be the solution, because to your point, there's a runway and we're running out of runway. And in your paper, you pointed out really clear that over the last several years for safety net hospitals, the cost has continued to increase, and yet the reimbursement for what they're doing has not increased. So as we're thinking about alternative payment models, within that also has to be reform around the existing payer system. Now, that alone is not going to fix it, and I agree with what your paper said about that. It is not. It's all these other dynamics as well, lost my thought there, have to be considered as well. How do we address the social determinants of health? How do we pay for that? All of those are critically important, but we cannot in the state of Illinois get away from the reality that adjustment to the current Medicaid payment needs to be made to enable the ecosystem for care delivery within Illinois, along with these other options.
Yeah.
I just didn't want to lose that.
No, I'm glad. I'm grateful to George for raising it, and I'm grateful for you also tacking on and adding a couple layers to that, because I think that's right. I do think about this a lot. I actually pride myself that every so often when I see Jay Shannon, I'll debate this a bit with him. There's no disagreement that that we are underfunded. Part of what I also heard you say, and forgive me or correct me if I'm putting words in your mouth, I'm intimating a little here, but there are also these opportunities we have to close this efficiency gap and get more for our dollar. And this becomes our classic healthcare complex chicken egg issue. On the one hand, I worry that if there was just a deluge of funding, do we go back to the baseline and status quo so we're out of funding again? That doesn't argue against doing it by any means. Alternatively, do we have an opportunity in the absence of that funding to try to close some of those gaps and really prosecute a case for that increased funding to further drive economic growth, prosperity, and health in communities? I think we all agree if we got a deluge of funding, we wouldn't turn it away, but you get the point.
Well, you get the federal match with it too. So,
Right.
you offset it with the federal match. And so and other alternatives like 1115 waivers and those sort of things to help enable the state to bring more money into the system.
Yeah. Well, and let me tack on that. I know we're just about at time, but Brenda, I think also one thing I was going to ask you, we won't have time to talk about, are institutions like the University of Chicago and other nonprofit health systems. Karen Teitelbaum talked about corporates. We talked a bit about payers. I've heard philanthropy come up a few times. Like, there are all these stakeholders that have this huge shared incentive, even if it's not just healthcare oriented. You can make the case for this in an economic development context, and you can make the case for it in a just human goodness context, what Mike Levitt calls the economics of goodness. And there are tremendous opportunities throughout the city, I think, as part of this collaboration. How do we bring those things together to augment what we don't have from the state and or the feds to make important capital investments in the community? And Brenda, I know that you and everybody on this call are spending a lot of time thinking about that, and we talk about it in the paper. So I think that's critical. Hard to imagine a scenario where the state's going to have much more than the 150 million that's been approved. I think there's an opportunity to make really good use of, again, uncommon bedfellows of an uncommon time. We are at time. I hate that these are only an hour. I wish they were like 4 or 5 hours because we could just keep going. Thank you for so much for joining and for the work you do in the city, and the powerful insights you shared. For those of you that joined us virtually today, thank you for being on, and those that watch it after. I'll just reiterate maybe the sentiment we all started with. We can do things today we could not do 5 or 10 years ago, full stop. We do not have another 5 to 10 years in the tank. And in the meantime, as George Miller said, drive 20 minutes, lose 20 years. What would you do for 20 years? For you, your parents, your children, your siblings, whomever, we should apply that same vigor and ferocity at extending that opportunity to those that we share this city with. So I'm excited about the future and the path because of the things I've heard today and the things I see happening. And you four are right at the center of all of it. So thanks to you, thanks to all. And we'll look forward to talking again in the weeks to come.